Okay. So, hi, evening, friends. Evening, everybody, bache. And as we know each other pretty well, I'm Dr. Sushant Soni. And in this session, we will be having a look at the techniques used in hematology. An extremely important session, especially with respect to the students who will be giving this NEET 2021 as well as the mid-year INA exam. This is so because all these are the prospective questions which you have to know with respect to hematology. In our this session, we'll be having a look at three main techniques, that is TEG, thromboelastography, TEG, thromboelastography, protein electrophoresis, and flow cytometry. These are the three main techniques which we will be discussing in this session. So let us start. Let us start with our first technique, that is TEG, thromboelastography. What do we do in thromboelastography? Thromboelastography, which this is used for rapid assessment of the entire coagulation pathway. This was the exact question, easy one, which was asked in this INI paper also. कुछ भी नहीं था. The question was for rapid assessment of entire coagulation pathway. The technique used is PT, PTTK. You very well know that PT is for the extrinsic pathway. PTTK is for the intrinsic pathway. You know that. So for the entire coagulation pathway, we use thromboelastography. What happens in thromboelastography? Let us see this in more detail. देखो, this is a graph. This is the graph of thromboelastography. This is the TG graph. The first part of the graph looks at clot formation, followed by the second part which looks at fibrinolysis. Let us start first with clot formation. In clot formation, there are three parameters. The first parameter is R, that is the reaction time. The first parameter is the reaction time. Let me keep on writing this side by side. R or reaction time. Reaction time, this is the time taken between initiation of coagulation cascade. This is where the coagulation cascade started. This is where it started. It is the time taken between initiation of coagulation cascade, to the formation of initial fibrin, to initial formation of fibrin. This is reaction time. This is where the initial formation of fibrin begins. This is where the fibrin formation starts, to initial formation of fibrin. That is the reaction time. Next is K. That is the kinetic time. Let me slightly reduce this magnification so that I am able to write this here only. Next bache is kinetic time. As you are able to make out, this is the kinetic time. It is the time period between the initial formation of fibrin. Kinetic time, it is the time period between initial formation of fibrin. So I can safely say that this is where fibrin formation starts. Initial formation of fibrin to specific clot firmness. The specific clot firmness is taken as 20 millimeters or 2 centimeters. This is the kinetic time. Dekho, we have just, for those of you who have joined us slightly later, but we have just started with thromboelastography. So firstly, thromboelastography looks at the whole coagulation cascade. It sees both clot formation as well as fibrinolysis. In clot formation, you had reaction time, which was the time period between initiation of the coagulation cascade to fibrin formation. This is the point where fibrin formation starts. Next was K. K is the kinetic time. Which is the time between initial formation of fibrin to specific clot firmness. This is K, and the specific clot firmness for kinetic time is taken as 20 mm or 2 centimeters. It's the same thing. Next is alpha angle. Look at this angle. This is the alpha angle. As you're able to make out, more is the alpha angle, it means more rapid is the clot formation. So next is alpha angle. It is an angle, so it will be in degrees. Alpha angle, it is the rate of fibrin formation. Alpha angle, which is this is the rate of fibrin formation and cross-linking. Rate of fibrin formation and cross-linking. That is the alpha angle. As you are clearly able to make out, if the alpha angle is bigger, or if the graph is more steeper, the rate of fibrin formation is more. Alpha angle. Next parameter is maximum amplitude. MA, that is maximum amplitude. Maximum amplitude, let me write it on the side only so that you are able to see the graph also. Maximum amplitude, this is the maximum clot strength. Maximum amplitude is the maximum clot strength. And the last parameter is Ly30, that is lysis 30 or lysis 30%. It is the same thing. Lysis 30, that is fibrinolysis, which is taking place after 30 minutes. Lysis 30, this is fibrinolysis occurring after 30 minutes of maximum amplitude. 30 minutes of maximum amplitude. This is thromboelastography. These were the various parameters that we see on the graph. Please have a good look at this. Kuch bhi nahi tha. First was clot formation, followed by fibrinolysis. Clot formation had reaction time. The first parameter was the reaction time, which was the time between initiation of coagulation cascade. This is where the coagulation cascade started. Initiation to initial formation of fibrin clot. This was initial formation of fibrin clot. Next was the kinetic time. Kinetic time was the time period between formation of fibrin, initial formation of fibrin, to specific clot firmness. That clot firmness is taken as 20 mm. Next was the alpha angle. Alpha angle, it was the rate of formation of fibrin, rate of fibrin formation. That is the alpha angle. Next is maximum amplitude. That denotes clot strength. That is the maximum clot strength. And last is Ly30. Lysis 30. Lysis at 30 minutes. Fibrinolysis, see, like Ly30, starts from maximum amplitude. So fibrinolysis occurring after 30 minutes of maximum amplitude. That is Ly30. So these are the various parameters that we see in thromboelastography. Next point. Let us now have a look. Now, before we go further, is there too much of echo? There is no reason for echo to be there, yaar. Okay, I'll take care of the sound. I've just seen the comment section. I'll be taking care of the sound which in the next one. Absolutely not to worry. Next point. Echoes are there. Okay. Next point. This gets us to a much more important point. That is, what if there is a problem in a particular component? What would be the therapy? What will that problem denote? And what will be the therapy for the same? Let us start with R. That is reaction time. Reaction time, it was the time to starting the formation of the fibrin clot. If there is a problem in fibrin clot formation, that means it is a problem with coagulation factors. This denotes a problem. This denotes a problem with coagulation factors. Coagulation factors were either deficient or they were inhibitors against the coagulation factors. as a result of which the reaction time was increased. What is the therapy? I want you guys to tell me this. If there is a deficiency of coagulation factors, which blood component is given? Platelets, FFP, cryoprecipitate, RBCs, packed RBCs, FFP, fresh frozen plasma, FFP. FFP is rich in all coagulation factors except factors 5 and 8. So if there is a problem with coagulation factors, which we give FFP. Next was the kinetic time. Kinetic time was the time until the clot reaches a fixed strength, and that strength was 20 mm. That strength was 20 mm. Now, if the clot strength is not being reached, it means there is a problem with fibrinogen. That means there is a problem. There is a problem in fibrinogen. Now, what will be the therapy that you will prefer in this case? FFP has fibrinogen, but what is rich in fibrinogen? Cryoprecipitate. Cryoprecipitate, which you know this from blood banking. Cryoprecipitate. It contains precipitated proteins from FFP. Let me write this on the side so that you will be able to recall this better. Dekho. FFP, fresh frozen plasma. It was rich in all coagulation factors. It was rich in all except factors 5 and 8. All these are the questions which are asked except factors 5 and 8. Next was cryoprecipitate. Cryoprecipitate, it is rich in, answer, cryoprecipitate, which it is rich in factor 8, von Willebrand factor. These are not the options, these are the substances cryoprecipitate is rich in. It is rich in factor 8, von Willebrand factor, factor 13, and fibrinogen. This is what cryoprecipitate is rich in. So if there is fibrinogen deficiency, as is denoted by an increased kinetic time, we will prefer cryoprecipitate. Next was the alpha angle. Alpha angle was the speed of fibrin accumulation. Again, if the speed of fibrin accumulation is not right, that means there is a problem in fibrinogen only. And again, the therapy for the same is cryoprecipitate. Nothing new. Therapy of the same is cryoprecipitate. Next, maximum amplitude, MA. Maximum amplitude was the highest vertical amplitude which denoted clot strength. If there is a deficiency, if there is a problem in maximum amplitude, it denotes a problem with platelets, and we give platelet aggregates. For the same, platelets are given. Now, before we go further, I want you guys to tell me this. Actually, what is the storage temperature for platelets? I am waiting for an answer on this. What is the storage temperature for platelets? We store them at minus 70 degrees Celsius, minus 30 degrees Celsius. Room temperature, 4 degrees. Everybody, I want all of you to tell me this. Agreed, we store them here. Totally agreed, but we store them at room temperature. That is 22 to 24 degrees Celsius. Next is L/30. Lysis at 30 minutes. If the lysis at 30 minutes is increased, that means excess fibrinolysis is taking place. This denotes excess fibrinolysis, and the therapy for the same is tranexamic acid. You know this very well from pharma also. Therapy for the same is tranexamic acid. This is PEG. This which is thromboelastography, reaction time, kinetic time, alpha angle, maximum amplitude, that is MA, and L/30, lysis 30. This was the graph that we saw. Thromboelastography looks at the entire coagulation cascade. Perfect. Important. This was your first technique, that is thromboelastography. I hope everybody is comfortable with this. Next point. This gets us to our next technique. This gets us to the next one, that is protein electrophoresis. Now have a look at this one. Nothing is given in this, simply the fact that this is serum protein electrophoresis. The examiner can ask you this either by putting an arrow on any of the bands which you see in this protein electrophoresis, or he can give you a graph of the same. We will have a look at both of these in detail one by one. देखो, first of all, proteins are negatively charged. So they migrate from cathode to anode. They migrate from cathode to anode. This is migration of proteins. First point. That is, we have put the sample here. This is the well or the point of the sample. Now, farthest from the point of application of the sample is the thickest band of albumin. Farthest from the point of application is the thickest band. It is the thickest band of albumin, followed by alpha 1 globulin, albumin. Next is alpha 1 globulin. Next, alpha 2 globulin, alpha 1, alpha 2 globulin, beta globulins. All these bands are that those of the beta globulins, and the last is immunoglobulins. Beta globulins and immunoglobulins. This is protein electrophoresis. Albumin, alpha 1 globulin, alpha 2 globulin, beta globulin and immunoglobulins. Let us see this in slight more detail. देखो, the main alpha 1 globulin is alpha 1 antitrypsin. But the main alpha 1 globulin, it is alpha 1 antitrypsin, which is an acute phase reactant. Alpha 1 antitrypsin, which is a acute phase reactant. Acute phase reactant means it is increased in infections. Next is alpha 2 globulin, that is alpha 2 macroglobulin. Again an acute phase reactant. Now between these, a better acute phase reactant which will be elevated more, that is alpha 2 macroglobulin. So if you have to mark between alpha 1 antitrypsin and alpha 2 macroglobulin, you will be marking it as alpha 2 macroglobulin. Next, beta globulins. These are the haptoglobulins. Beta globulins, these are the haptoglobulins. What happens to haptoglobin levels in hemolytic anemia? In hemolytic anemia, because of the hemolysis, hemoglobin binds with serum haptoglobin. As a result, haptoglobin reduces. Again, this is asked from RBC disorders. In hemolytic anemia, haptoglobin reduces. The other beta globulins are beta lipoproteins. Others are beta lipoproteins. Let me drop this off. Beta lipoproteins and serum transferrin. Beta lipoproteins and serum transferrin. What is the role of serum transferrin? Iron is transported in blood bound to serum transferrin. You know that. Which form of iron? I'm waiting for your answer again on this, Vijay. Which form of iron binds with serum transferrin? Ferrous or ferric? Ferric. Fe3 plus. That is the ferric form. Ferric form binds with serum transferrin. Next point. These were the proteins that you see in protein electrophoresis. Now, every time I have to give a report to the clinician, I will not send him this whole protein electrophoresis chart. We can depict the same as a flowchart also. So, if I have to make a flowchart of the same, I can denote it as albumin. This is the broadest and the biggest band of albumin, followed by alpha 1 trypsin, alpha 1 globulin, alpha 2 globulin, beta globulin and gamma globulins. Albumin, alpha 1, alpha 2, beta globulins and gamma globulins. I can depict normal in this manner also. Next, now you tell me the diagnosis. Suppose a graph is given. Like this. Albumin, alpha 1, alpha 2, beta and gamma globulins. Suppose you have a graph like this. Diagnosis. Answer bache. Diagnosis. What do you see here? Here, albumin has reduced. Albumin has reduced versus gamma globulins which have increased. AG reversal. Albumin to globulin ratio reversal. AG reversal. Next point. Is it a monoclonal band? No. What you see here, normally the answer that I usually get in classes is it's a case of multiple myeloma. Nahi bache. Here there is a polyclonal increase. This is a polyclonal increase in gamma globulins. This is a polyclonal increase in gamma globulins. Multiple myeloma will show you a monoclonal band. This is a polyclonal increase in gamma globulins with AG reversal. Diagnosis, hepatic encephalopathy. A very common mistake that students make is they call it as multiple myeloma. This is not. This is a case of hepatic encephalopathy. Next. Now, agreed, Vishal, totally agreed those. Next, now have a look at this. Albumin. Let me draw this again. Albumin, alpha 1 globulin, alpha 2 globulin, beta globulins, and gamma globulin. This was your favorite. What you see here is a M band. M stands for IgM, myeloma, या monoclonal. M stands for monoclonal band in the gamma region. It was not IgM or myeloma. M was monoclonal band in the gamma region, which is making a diagnosis of multiple myeloma. So do not confuse hepatic encephalopathy. A very common mistake, very common mistake with multiple myeloma. Lastly, agreed. Lastly, have a look at this. Albumin, alpha 1, alpha 2, beta globulin, and gamma globulins. What do you see here? I have slightly reduced the magnification so that you are able to see all the 4 graphs in the same slide only. What do you see here? Bache, here albumin is okay, alpha 1 globulin is okay. Beta globulins have alpha 2 globulin, which was alpha 2 macroglobulin, which is an acute phase reactant, has increased. So this denotes an increase in alpha 2 macroglobulin. This is an acute phase reaction. It is an infection. Or an acute phase reaction. Perfect. This was protein electrophoresis. And lastly, now that we are doing electrophoresis, let us have a look at hemoglobin electrophoresis also. So this gets us to our last topic for today in the techniques for hematology. Flow cytometry, we'll do it in the next session, that too in much more detail, because flow again is extremely important. So this gets us to hemoglobin electrophoresis. We had a look at 3 main techniques in our this session. Thromboelastography, very important. I will not be astonished if you have a question either in NEET or the AIIMS exam for the same. Thromboelastography. Next, protein electrophoresis, and last is hemoglobin electrophoresis. First point, hemoglobins, they are again negatively charged. Hemoglobins, which they are negatively charged. So they migrate from cathode to anode. That is, they migrate from negative to positive. They migrate from cathode to anode. Next, let us have a look at hemoglobin electrophoresis. Suppose this is the agarose gel plate. This is the agarose gel plate. This is the point of application. That means I have put the sample here. This is the point of application. Whenever hemoglobin electrophoresis is given, normal is always put. There is no hemoglobin electrophoresis without normal. What do you see here? Normally, we see the thickest band of HbA. Normally, we see the thickest band of HbA farthest from the point of origin, followed by HbF, which is close to HbA, and HbA2, which is closest to the point of origin. This is normal. Dekho, you know the normal percentages of hemoglobins as such. Before we go further, I want you guys to tell me this, which in normal hemoglobins in adults, तीन main है, HbA, HbA2 and HbF. HbA is alpha 2 beta 2. Normal hemoglobins, HbA is alpha 2 beta 2. HbA2 is alpha 2 delta 2. Please don't call it as gamma, alpha 2 delta 2. And HbF alpha 2 gamma 2. Which is the predominant hemoglobin? HbA. How much? It is about 95 to 97%. Now, I am not concerned even if you call it as 94 to 95, 94 to 96, 95 to 97. I am comfortable with it. HbF is less than 1%. 0 to 1, 0 to 2, less than 1, less than 2. I am okay with it. Mean is HbA2. We cannot change it. Normal HbA2 is 2 to 3.5%. This is fixed, which you cannot change it. Why am I laying so much stress on this? Because in thalassemia minor, in thal minor, HbA2 is increased. That is the main point with respect to thalassemia minor. HbA2 is increased. Normal was 2 to 3.5. Increased means it is more than 3.5%. But I want you guys to tell me this. But what is the upper limit? Dekho, even 50% is more than 3.5%. What is the upper cutoff of HbA2? But less than 8%. Very, very important. To make a diagnosis of thalassemia, HbA2 is more than 3.5, but it has to be less than 8%. This is normal. Next point. This gets us to back to our gel hemoglobin electrophoresis. Normally, HbA was the predominant hemoglobin, 95 to 97%. It is the farthest from the point of origin. It was same as protein electrophoresis. Even in protein electrophoresis also, albumin was the thickest band and it was farthest from the point of origin. Easy to remember, they are similar. Next, starting with thalassemia, starting with thal minor. HbA2, low, normal, high. It is high. Is it markedly elevated or slightly elevated? Slightly increased. Remember, it was more than 3.5 but less than 8%. So HbA2 slightly increased. HbF, normal. HbA, low, normal, high. It is slightly reduced. Jitna HbA2 increased, to the similar extent HbA reduced because the total has to be 100%. But to the naked eye, I will not be able to see slightly reduced HbA. What I will be able to see is slightly elevated HbA2. This was thalassemia minor. Next is thalassemia major. Next is thal major. HbA2 normal. Now the predominant hemoglobin is HbF. So HbF markedly increased. Predominant is HbF, markedly increased, whereas HbA is markedly reduced. Thal major. Actually, before I go further, I'm very curious. What is the difference between thal minor and thal major? Thal minor, which is thalassemia, is autosomal recessive. Thal minor means it is a heterozygous state. One allele is normal, the other is abnormal. It is heterozygous. Versus thal major, that is a homozygous state. Both the alleles are abnormal. You know that each gene locus has two alleles. Thal minor is heterozygous versus thal major, which is homozygous. Next is sickle cell trait. Sickle cell trait. HbA2 normal. Now you have a fourth band of HBS which migrates between HbA2 and HbF. HbS. Next, HbF. Low, normal, high. In sickle cell, HbF is slightly elevated versus HbA which is reduced. जितना HbS and HbF was increased, उतना HbA is reduced. Total has to be 100%. Before we go further, tell me this also. This elevated HbF, is it good for the patient or bad for the patient? HbF is increased. Is it good or is it bad for the patient? But it is good for the patient. Why? HbF has more affinity for oxygen. What was the problem in sickle cell anemia? The problem was that HbS polymerizes on deoxygenation of RBCs. HbF has more affinity for oxygen, so it prevents polymerization of HbS. Thus, elevated HbF is good for the patient. It is good. Sickle cell trait. And last is, totally agree with you. Then last is sickle cell anemia. Last is sickle cell anemia. HbA2 normal. Now we have the predominant HbS. Sickle cell anemia. HbS is predominant. HbF is slightly increased versus HbA which is markedly reduced. Versus HbA that is markedly reduced. This is hemoglobin electrophoresis. What do we mean by trait versus anemia? Same thing. Sickle cell is also autosomal recessive in nature. So sickle cell trait means it is a heterozygous condition versus sickle cell anemia, that is, it is homozygous in nature. Same like thalassemia. Done. This takes care of your three main techniques in hematology, that is thromboelastography, protein electrophoresis and hemoglobin electrophoresis. Next point. Now, before we wrap up the session, now the date for NEET exam has been announced. I guess everybody knows this as a fact now that it is 14th of April. So those who were slightly, लोगों का पढ़ने का थोड़ा मन कम था because of the uncertainty with respect to the date, we were not able to concentrate so much for whatsoever reason. Now all the factors are out. Now absolutely all the factors are out. The exam date is there. As a result, was it 18th? Yes, my mistake. Totally agreed. It is 18th. It's the Sunday. I have no idea why I confused it with 14th. 18th April. So, bache, for the same, I'll be starting tomorrow morning. I'll be launching a crash course in pathology. We'll be doing path. I'll totally take care of your whole path. So those of you who have studied it once will be considering it as a revision module. For those because of COVID duties or whatsoever reason, you were not able to do it. So this will take care of your pathology totally. Crash course in pathology, which will be of 20 hours of duration. It will be absolutely free. I'll be putting the link of the same on my Telegram group, the class links tonight only. And the second is the grand test in pathology series. Grand tests in pathology, we will be having a look at 4 grand tests in pathology, around 150 or 100 to 150 questions in each test. Majority of the questions in the paper. With these 4 grand tests will take care of majority of your questions. I'll be updating the links of the same on my Telegram group today, and needless to say, bache, bestest of luck for the paper. This is the link of my Telegram group, and looking forward to seeing you with good results. Thank you, and take care.